This week on the BackTable podcast.
Underselling a lot of the pain procedures is, in my opinion, not a bad strategy, just to really temper expectations. The problem is that we have so many patients that come to us for different pain procedures that we do. And while we're obviously trying to improve pain, it's not like, okay, this is this new procedure with one thing we're going to do and all your pain will be gone. And I try to get that point across is my goal is reduction of pain, not elimination. And if I tell them that's going to be eliminated, then the problem is that I think that word gets ingrained and they hold on to it. And when it maybe is reduced, but not completely gone, that's where the quote unquote poor outcomes may come from. So something to keep in mind as you're talking to patients.
Thanks for joining in today. I have John Smirniotopoulos, who's an interventional radiologist at Georgetown and MedStar Washington Hospital Center. Been practicing interventional radiology for a while, has built a genicular nerve ablation practice from really nothing. Has been doing it for several years. So welcome, John. Thank you so much for being here. Appreciate your time this morning.
Yeah, thanks for having me. Excited to be here.
I've been looking forward to this topic for a while, and I guess I should introduce myself as well. Kabi Krishnasamy. I'm an interventional radiologist at UAB and primarily do interventional pain and interventional oncology. So John, let's get started. Tell me, where exactly did GNA start? What's the history of GNA?
Yeah, so I think the history of GNA really started with the history of other nerve ablations in the body, like rhizotomy. Taking a needle probe, doing radiofrequency ablation or some other type of generated ablative property to a peripheral nerve that innervated a joint, right? And so the rhizotomy or facet ablations, or now we perform medial branch nerve ablations, expanded into other joints of the body. What else could be treated? And so osteoarthritis of the knee became something very important, very prevalent, obviously, in the United States and abroad in terms of, is there something beyond surgery or maybe before surgery or even after surgery that could be done for these patients? And so in 2011, we have a randomized controlled trial by Choi, a pain physician that was doing this on 38 patients. It was a sham trial. So, essentially needles go in, either you do the neurotomy or you don't. And there was a significant reduction of VAS and KOS. So both function and pain were dropped. So that was, over 10 years ago, but a very important study that was done targeting 3 genicular nerves to help these patients out. And since then, the data, the trials, and the modalities of ablation have expanded, been reproduced. And now you have additional randomized control trials that have been performed with other minimally invasive procedures, conservative measures for the osteoarthritis. So we look at 2011, we look at that study as a nice jump off point with good randomized data. Okay,
good to know. That was a while ago. I was a resident at that time. So that's fantastic. And I do want to dive into, some of the comments you made. We'll do that here in a little bit. Before we get there, talk to me about the anatomy of the genicular nerves. And I know that's complicated. So, yeah.
It is complicated, and it's a good subject to go into because it's been reanalyzed over the years. So the principle of genicular nerve pain intervention follows what's called Hilton's Law after Dr. Hilton, right? Where you have a nerve that goes towards a joint. Those nerves innervate the muscles, but they also innervate the joint itself in terms of a sensory as well as cutaneous components of it. And so we looked at some of the early cadaveric studies of those nerves supplying the knee. Some of them are from the 90s. Some of them are more recent, especially as more understanding of the genicular nerves were required. In general, you have the femoral nerve, right? And you have the sciatic nerve. And I think of those as major trunks. Now, you also have the operator nerve as well, although we think more primarily we're innervating the thigh and hip with the operator. So if we kind of focus on the femoral nerve and the sciatic nerve, you're going to have afferent sensory nerves and efferent motor nerves that go to the muscle and then cross the joint. So from the femoral nerve, you have a posterior and anterior division. The posterior division has sensory articular branches to the hip and the knee. And then the posterior division of the femoral nerve becomes the saphenous nerve as it goes to the adductor canal. It's very important because the saphenous nerve does supply most of the medial compartment of the knee. And we do see a lot of medial compartment predominant osteoarthritis in patients. So it's something to remember because that seems to always be a little bit of the trouble spot when we're dealing with knee pain. The sciatic nerve bifurcates into a tibial and common peroneal nerve right above the popliteal fossa. And so again, you have femoral, you have sciatic nerve, you have them turning into other nerves and bifurcating as they go down the leg. But importantly, you have a different distribution supplying different compartments of the knee. And so you have the supermedial genicular nerve, which often comes from the vastus medialis. You have the superlateral genicular nerve, which often originates from the sciatic nerve, but variably you can have innervation coming from the vastus lateralis. Then you have the inframedial genicular nerve, which is a branch of the saphenous. We also know that you have a infrapatellar saphenous branch that also obviously comes from the saphenous nerve, and that's one of the ones that wraps very superficially anteriorly to the tibia. And then you have the suprapatellar genicular nerve, which is an articular branch of the nerve supplying the vastus intermedius. And so that's the suprapatellar recess that innervates. And the reason I bring this up is initially the early data, the early studies were done off of kind of a couple of select cadaveric dissections. We were targeting 3 nerves. However, since then, additional cadaveric studies have been done. Upwards of 11 nerves have been described in some of the literature. However, probably more importantly, there's a study from Fonku that was performed in several cadavers that was trying to find essentially a predictability of the nerves. And there's really 5 articular branches that are fairly consistent in terms of their anatomic location. That's the supermedial genicular nerve, the inframedial genicular nerve, the superlateral genicular nerve, the infralateral genicular nerve, which we often don't target, and then you have the infrapatellar saphenous branch. So as this procedure has been done, as more people are doing it, the understanding of the anatomy has grown, and really that's attributed to multiple cadaveric studies that have really expanded our understanding of the innervation of the knee. And it's, like you said, it's not simple. I know we target 3 nerves or maybe 4 nerves, but it's not just that. And I think that's an important part when you're discussing the benefits, and maybe the way to phrase that is the limited benefits with a patient. We're not targeting every single nerve here.
That's a great point. So, obviously on the sciatic side, tibial and peroneal are going to have motor components, right? So you really have to target them around the knee. What about on the saphenous side? Is that only sensory? Could you theoretically target that at a different location higher up the thigh, something like that? I know that's a little bit outside the box.
Yeah, so I think the issue is if you were to target it for an ablative, like a thermal or cryoablative purpose, for the purpose of nerve destruction, you would start having issues with calf and really below the knee motor function, in addition to some of the sensory function of the skin as well. Now, that brings in the other question, okay, what about other modalities of treating these nerves, like a pulsed RF, which doesn't cause a thermal injury? You have like a stunning effect. Is there a benefit there? That, and to that point, you do have peripheral nerve stimulators that some people do place for knee pain. And when they place them, the location of placing those is actually not typically around the knee. The reason for that is you worry about getting to the capsule with these stim placements. So they place them higher up in the thigh. They're really trying to get more of the trunk of the femoral nerve at that point. So while you could target something a little more proximally, a little more centrally, with a more destructive procedure like thermal or cryoablation, I believe you do run the risk of taking out some of the motor components and therefore causing muscular dysfunction.
Okay, so even the saphenous nerve has some motor component to it.
Yes.
Got it. Okay. Yeah. All right. So we talked a little bit about the variability as well. And it's interesting because most people target suprapatellar and not infrapatellar, right? But obviously, as you said, that's one of the more less variable, I should say, nerves that potentially could be targeted. And we'll get into that a little bit later. So what is your technique? What are the nerves you target? What are the locations you treat?
Yeah, so I target 4 nerves in particular. So I do supermedial, superlateral, inframedial, and then suprapatellar. The reason I do the suprapatellar, that 4th branch, and not everyone does this, but there was a study that was done by Wong and Felix Gonzalez, who is a radiologist, is on this paper as well, and he's very well versed in genicular nerve ablation and the genicular nerve anatomy. And so that 4th nerve was targeted as a potential problem nerve because of the location of how it runs to the suprapatellar recess. And that 4th nerve showed superiority in terms of a 4-nerve versus 3-nerve ablation at 6-month follow-up for 50 patients. Now, it's a retrospective study. However, there was superiority there. And so that's why I target 4 nerves. The way I do it, like most people, I would imagine, we do a nerve block, a prognostic block. I do mine personally under fluoro. You can do this under ultrasound as well. If the patient gets 50% reduction of their pain or more, then they would be eligible for the ablation. In my practice, I commonly use RF, cooled RF, just for my ablative purposes. And I'll target those 4 nerves. I think importantly, maybe what I do a little bit differently, and I think some people are starting to adopt it, is I'll do what I call the pullback technique for the superior and supermedial genicular nerves. What I mean by that is I will have my probe go about 2/3 shaft depth in the lateral view. I'll do an ablation there, and then I'll pull to 1/3 depth and do a second ablation. And the reason behind that is while there is consistency with the location of supermedial, superlateral, there is still some variability there. There's a good study that was put out by Cornell, I believe in 2020 or 2021, looking at MRI and predictability of where these nerves lie based on the neurovascular bundle on a PD sequence, and then correlating that to where an ablative probe may be and the ablative size that would generate from that. And so the ability to get kind of quote unquote on target with the probe itself to have that nice thermogenic effect, depending on the size, was more variable, the supermedial, superlateral. It's not too off, but it's like 88% predictable. And so in my mind, if we're visualizing things in our flora, right, we're not actually seeing the nerve with this. And even with ultrasound, I still have a hard time believing that you're correctly identifying the nerve. I think you can see the neurovascular bundle, but there's variability in that as well. And so because of that, I do almost like a 5-point ablative technique, or again, what I call the pullback technique, but specifically for supermedial and superlateral genicular nerves.
And so the 5-point refers to supermedial, superlateral twice, and then plus inframedial, and then plus minus suprapatellar?
And I always do suprapatellar for mine.
Okay.
Yeah.
Okay. Got it. And then so why don't you use that technique for inframedial? Is inframedial just more predictable in terms of its location?
It's more predictable, and if you think about the depth of the tibia on the inframedial side, you're going to get very close to skin as you pull back. And so I do worry about thermal injury to the skin.
So that's a great question. Something that I'm always cognizant of in my practice. Obviously, with arthritis numbers on the rise, and then BMI also on the rise in a lot of places in the world, it's less of an issue. But we do see patients that have relatively thin, subcu tissue around the knee. How do you approach those patients? Knowing the expected size of the ablation zone, is it something that you worry about at all in certain locations where there's just not a lot of subcu tissue?
Yeah, I definitely. And so for me, the area I would worry about would be against the tibia. And so you do want to have 2 centimeters of depth. So if you're using a cooled RF probe, your predictive zone is going to be about 1 centimeter of ablative temperature. And so you want to have that buffer from the skin. But it's always on my mind on a very thin patient. The benefit of a cooled probe is that you don't have to necessarily be parallel to the nerve. You can come in a different angle. And so if you have to adjust to get that depth, you can. And this may be where some of the liquid neurolytic agents out there, like ethanol, may play a better role, is that if you do truly have someone where you can't get that depth, you're worried about hitting the skin. If you turn to ethanol as an example, you might be able to disperse and spread. You're not going to really be at much risk of causing a skin injury. That being said, we do a couple hundred of these a year, and I haven't seen a thermal injury for any of these patients. Now, the one area, and I know you and I had chatted about this, is this infrapatellar saphenous branch. That's really, really just on top of the tibia there, anteriorly, right below the patella. I think that's, to me, it's always a trouble area. Patients, if they had come back with medial knee pain, I feel like that's the branch that we're probably not treating effectively. And I think that is also the area where we are a little more limited in terms of our ability to treat that based on our ablative zones. You'd have to have something pretty small there. Some people have done cryo with iovera as an example, and it seems to work well. I worry about a thermal injury to the skin absolutely at that point. And so that absolutely plays a role in my decision in terms of treating it or not treating it, or maybe trying to think outside the box a little bit for that area.
Sure. It's as you said, it's a very difficult area to treat. What about inferolateral? Is there any incremental gain to treating inferolateral? Obviously, there are complexities around that as well. Talk to me about inferolateral.
Yeah, so inferolateral, it's interesting, right? I think you and I had chatted about this offline. We both happen to stumble on the same studies that were looking at it. And there is a study that demonstrates the ability to treat that inferolateral compartment of the knee with RF or an ablative property, where the needle effectively goes in between the fibula and tibia at the fibular neck, just AP view, goes straight down, and you confirm on a lateral. However, the data doesn't suggest that it offers any superiority in terms of pain reduction compared to avoiding that area. So certainly I would be very hesitant about putting my probe on the lateral margin of the fibula. I'd absolutely worry about foot drop with that, but there is data to show that it is safe to go into that notch there between the fibular neck and tibia. But the outcomes, I don't think necessarily justify going in that region. The times I think when you can think about is if, again, you've treated, let's say 3 or 4 nerves, you haven't treated that nerve, a patient still has very focal complaint at the lateral compartment, it may be worth doing a block and then doing an ablation there.
Okay, got it. So a little more focused on location of pain. And that kind of leads me to my next topic as well. So outside of supramedial, supralateral, inframedial, suprapatellar, case by case for infrapatellar and for infralateral, is there anywhere else that you potentially would treat? Any other gains from any other nerves?
Yeah, so I think the issue becomes when there is focal pain at certain compartments and what to do then. And then you have to wonder, are the nerves really what's going on, or do you have to think, maybe should we look at GAE or something like that? And so there's an 11-point technique that's been described in the literature, but it is focused really around the knee, and you have to wonder once more, are we dealing more with maybe a synovitis issue that's going on, and that's what's causing the pain? And so when I see patients where we've kind of done everything, we've exhausted everything, and their pain is still there, it's reduced, or they have pain come back earlier, we start thinking, okay, what other modalities can we try? One thing, though, I do like is trying ethanol, right? If you've done an ablation, let's say you've done the block works great. Then you do an ablation. Ablation works great for a month or 6 weeks or 3 months, but it doesn't last very long. And the patient comes back and says, hey, clearly the block worked. The ablation worked, just very short-lived. What can you do? And again, I think this is where liquids may play a role. And I've done this before in refractory cases. It's not very common, but I've seen it certainly. And this is what we've changed our practice to accommodate is we would go in with a 75% ethanol concentration and then bupivacaine to fill out the rest. I place 22 gauge spinal needles, just like I do for my prognostic block under fluoro, or you can use ultrasound. And I'll deliver a 1 cc volume of that cocktail. And in my mind, that is going to more closely mimic the distribution of your provocative block in terms of the spread, particularly in patients maybe who have had surgery before and there's scar tissue and things might not distribute in a very uniform pattern. And so I think that is something to consider when you are trying to think, okay, what else can I add to this patient from a nerve perspective?
So then is that your volume for your prognostic block as well, about 1 to 2 cc per site?
Yeah, exactly. And we try to really keep it at that 1 cc to really mimic what the ablative zone would be.
Got it. Okay, that's a great point. I don't know that, it's interesting in my practice when I was at Emory, we very commonly put 3 to 5 cc's in per site, but maybe that was too much. And there were definitely patients where we had a positive outcome on block, but did not have the same positive outcome on ablation, right? So to your point, I think that's very relevant. So I'm going to pivot a little bit, and I'm going to reach back to a topic. So I had the opportunity and privilege to debate Azamed at Guest MSK this year on GAE specifically, and how many vessels to embolize in GAE. I also had the opportunity and privilege to lose that debate very badly, but that's okay. It's still fun. So when we're talking about GNA, globally, I think we target all the nerves in the whole knee, right? Is there a role to target nerves innervating the specific site of pain or the specific location that is problematic for the patient? And then to pivot off of that, as you said, these patients that have trauma or TKA or scar tissue, and you can't really treat maybe necessarily the entirety of the knee, how do you approach those situations in when you think you're only going to treat part of the knee?
Yeah. So to start with, treating specific compartments, specific parts of the knee, I mean, it's obviously you want to identify where the pain is. In consultation, we always ask, where's your pain? Half the time, the answer is everywhere. Fine. But, I'd say the other half the time, it's the medial compartment for our patients. And every once in a while, it's just pure lateral. That being said, I typically treat all nerves. My thought is that these nerves, we're hitting trunks of the nerves before they further bifurcate or trifurcate, and they will almost form a mesh around the knee at different compartments. And there may be some components that cross over the knee to kind of connect with one another. Similar, like if you've done GAE and you'll get into one of the arteries, you'll start injecting your contrast to do a run, and you'll see, okay, this is interesting because the supraremedial is now connecting with the inframedial, and you're seeing a crossover. And I feel that if we don't treat those nerves, then we might have a suboptimal response. And that's part of why I also treated the suprapatellar. We brought that in our practice pretty quickly. Initially, when we started this, we didn't. We just did the 3. And then I started reading, the papers about the 4. And my thought was, well, if I don't get an optimal response by doing 3, I'm going to wonder, should I have done the 4th? To your point, though, there have been studies looking at the infrapatellar saphenous branch as a standalone nerve to hit when there's specifically infrapatellar pain and only infrapatellar pain. And that has not been randomized, but it's been looked at as a separate nerve, treating the separate nerve altogether with good results from that. So it's not unreasonable to try to locate the pain and treat it separately. However, I just, in my personal opinion, feel that we should really treat these major nerves, and then we can touch up that infrapatellar branch if we need to.
Well, it's a great point. And what's the downside, right? Unlike GAE with permanent particles specifically, right? I know we're transitioning to resorbable particles, but with permanent particles specifically, I mean, there is risk of, skin ischemia, skin ulceration, asymptomatic bone infarcts, things like that, with increasing number of vessels treated potentially. So what's the risk of really treating globally, nerve ablating the knee globally? There's really not, right?
Yeah, I mean, the biggest risk that you want to talk about obviously is motor dysfunction, and depending on what device you're using, you have the ability to stim for that. I will say, though, there is a risk, and I think it's probably underappreciated, of causing an osteonecrosis of the knee from thermal ablation. We've seen it on MRIs, in the short term, and there's a couple of cases out there in the literature. It has no surgical consequence because I've talked to our surgeons that have kind of use this as a bridge for knee pain prior to surgery, and they don't see any ill effect from it, which again is probably why they like it. But it's something to just keep in mind that there is that risk there. That being said, these risks are small, and we can manage them appropriately.
That's a great point. Is that more heat-based or cryo-based?
Yeah, so we do heat. That's how we got this kicked off a few years ago. But, I think cryo definitely has a great role to play. We're trying to get a randomized control trial off with cryo and heat just to see if one's better. And I would think that cryo would be, you'd have that neurolytic effect, but you maybe have a little more forgiveness with surrounding structures as opposed to heat. However, I don't see a limited function from our patients from the heat component, but we can get into, other risks of the procedure as well and what to expect.
Got it. Okay. But limited risk of osteonecrosis, things like that, potentially from cryo as well. Okay. Got it.
Yes.
So talk to me about some of the different commercially available devices. I mean, we hear pulsed RF, cooled RF, continuous/conventional RF. What do people need to know?
Yeah. So any of those technically work, right? There's a couple of meta-analyses out there that compare the literature for all 3. The data that was included in the meta-analyses are quite heterogeneous, as one would expect, not really showing a significant superiority of one over the other. And so we brought on Avanos CoolLeaf, which is a cooled RF, but also has the ability to do traditional and pulsed RF. Stryker makes Venom, Medtronic makes Accurian. There's a whole host of these that are out there. I mentioned Accurian is like a standalone little cryo probe as well. So with continuous RF, that is going to create an elliptiform heat that generates from the probe itself. You are going to have some destruction between 60 to 80 degrees Celsius. It is limited, right? Because with RF, you're going by conduction. And so if you start heating the tissue and creating char, your ability to conduct beyond that char is what's going to stop your burn, which is okay if you know what you're doing. But for the traditional RF, it's best to come in parallel to the nerve itself, so you really kind of get that ablative zone because it is going to be smaller. Pulsed RF is almost, think of it like an on and off, a rapid on and off switch for RF itself that really hits it at 42 degrees Celsius. So you're not going to have thermal destruction. You're going to have a stunning, and it goes, again, 20 milliseconds, right? So it's very high voltage burst, and then silent phase of 480 milliseconds. So it's a quick on, longer off, and it goes in this cycle to get to 42 degrees, but you won't have thermal destruction. That happens above 45 degrees. And then cooled RF runs saline or water through the probe, not into the tissue, to maintain a more consistent temperature of the probe itself. So you have thermal destruction at 60 degrees Celsius, but you are creating a more spherical and predictable shape of the ablative zone itself. So when in our practice, it just happenstance, we ran into the Avanos rep in a hallway one day and just started talking about the procedure. And we looked into a couple other vendors out there, but we just went with Avanos. And we've been doing that for over 3 years now and have had good responses. But that being said, I mean, many practices have other forms of RF equipment probably available to them, maybe even on their shelf that they could use for this.
So that's a great point. My practice has historically only used CoolLeaf as well. And frankly, the last time I used conventional RF, I mean, we don't use it in the liver anymore. I know it is still used worldwide, just with lack of access to microwave, right? But, we really don't use it for this application at all anymore. I didn't realize CoolLeaf had continuous and pulsed RF capability. Are you ever using either setting in this, for these patients, or is it only cooled RF?
No, I'm only using cooled RF for the peripheral nerve. And I use this for, knees, hips, shoulders, SI joint, medial branches. I use cooled for all of those.
That's awesome. Okay. And I know we hit on cryo a little bit. The only FDA-approved device that I'm aware of is iovera. Is there anything else on the market that you've used or tried?
So I've tried I've tried Boston Scientific, which has worked very well. iovera is a little bit unique in terms of how it's designed, right? It's a handle. So in terms of the purchasing component, you have a handle, you have disposable probes, cartridges. It's made to be done in an office setting if needed. It's a great tool if you use ultrasound for these. The reason fluoro might be a little tricky is because that handle is very heavy, and once you want to have the needle on the handle prior to putting the needle into the skin, right? So as opposed to having your needles in place and then hooking things up, and it's bulky, so that needle is going to probably flop over if you're just, trying to stand it with fluoro and switch between your AP and lateral. However, under ultrasound, it does work pretty well. And talking to colleagues throughout the country that have used it, they like it for an office-based outpatient setting.
Got it. And it doesn't use argon or helium. So what does it use?
I have to check on that. It's we've used it once in a test. I was going to say, I want to say it's nitrogen, but I have to check.
I could have looked as well. I apologize, John. I didn't mean to put you on the spot. You mentioned ultrasound versus fluoro. You can use either. Do you feel like one is better than the other? I traditionally use fluoro. I don't use ultrasound, even though I use ultrasound for lots of things. But yeah, tell me.
I started doing this with fluoro. I've done ultrasound before. I find fluoro just to be very fast and predictable. With ultrasound, I felt that I was consistently, obviously looking for anatomic landmarks, but I'm also trying to find the neurovascular bundle with ultrasound, which can be just incredibly difficult depending on patient size. Prior surgery, absolutely, it's going to be tough to see. And so I felt that I was trying to be, incredibly precise, which is not a bad thing. But I think that fluoro, we're just faster at it. I think for a throughput and just honestly, a patient's lying there, you're going to numb them up. They don't love having needles shoved in their knee. It just makes the experience a little bit better. So we use fluoro.
And we all have fluoro, right? That's the benefit of it. I want to go back to that surgical patient population and even the traumatic patient population as well. Do you feel like outcomes are different in that patient population compared to the native knee?
Yeah, so that's a great question. And we sub-analyzed our data and have found that, no, they're not different in that patient population. So we actually see a lot of these patients post-surgically who have either residual pain or maybe pain didn't change, but mobility changed after surgery, specifically for a TKA. And those patients do very well. There's no difference between those groups, at least in our patient population. But another question would be, what about, like a meniscal injury or something of that nature?
Something structural in the knee? Yeah.
Yeah, exactly. And it's interesting because we actually do get those patients referred to us quite a bit by our sports ortho colleagues. Definitely not to the frequency as native knee osteoarthritis, but we also looked at that in our data set, any type of prior, meniscectomy or other repairs. And those patients also do well. Not that everyone, gets that 50% reduction or more, but we still have a statistically significant improvement in both VAS, and we collect WOMAC scores for all these patients as well. And so we haven't really found that we should be excluding those patients from this procedure if, they're referred to us.
Got it. What about sports injuries?
Yeah, so sports injuries, we're going to have them evaluated, obviously, first by a sports orthopedic surgeon. They're probably going to go through PT, and if they're non-surgical, and they still have pain after PT, then they would come to us, and we've seen that as well.
Okay.
Yeah, and I counsel those patients. I tell them, look, this is not osteoarthritis. This procedure from the data works better for that. However, in our practice, anecdotally, we've seen patients with sports injuries come, done PT, maybe get some degree of pain reduction, not full, and do well after the procedure. And honestly, if we do a test block and it doesn't work, that's okay. The test block itself is at least worth trying.
Yeah, it's a great point. I think it's part of what's led to the revolution in local therapies around joints, right? I mean, plantar fasciitis and epicondylitis and bursitis and, arterial embolization as well. So it's interesting as you continue to see more patients like that, what that data will kind of bear out and show to us. So that's fantastic. What about pre-TKA? Do you think there's a role to nerve ablation prior to surgery to help with outcomes? And yeah, go ahead. Sorry.
I think that's a great question. And so it's actually been studied. There's 2 randomized control trials not showing a positive effect. However, if you look into those trials and you look at the timing of the ablation relative to the surgery, it was a very short, within order of a couple of weeks or a few weeks time frame between the ablation and then the surgery. And we know based on the Wallerian degeneration that it can take up to 6 weeks, right, to have a full effect of the nerve ablation. And so I really do feel that maybe if we had done those studies with a little more lead time, that 6-week lead time, that we would see an effect, because that's what we do in our practice when we have this quote unquote bridge to surgery for pain reduction. We are, doing it at least a couple months before surgery to allow that nerve to really kind of, die off. We also send them back to PT and try to optimize their pain. And thus far, the feedback from our surgeons is that it's actually helped quite a bit in terms of post-operative pain reduction, adherence to physical therapy, and reduction of oral medications.
Oh, fantastic. So locally, you're having success. Got it. Good. Go ahead.
Yes. And the goal would be, and I've talked to some of my partners about this, about doing another randomized control trial, but with a longer lead time. And that would be the goal. Because that's when we hit that sweet spot, prior to surgery.
And max effect, you said around 6 weeks.
Yeah, exactly.
Okay.
Exactly.
Got it. Okay. And so you do GNA and GAE, obviously. How are you deciding between the two patients? That is the, the big elephant in the room, right? And that's the controversial topic. Yeah.
Yeah. I've said this before at Guest, and I said it at Edge. I think this is what allows us as physicians to be a little unique, right? We can do both. We have that ability to go into the arteries. We have the ability to target nerves based on anatomic landmarks. So we can have a couple of tricks up our sleeve if one doesn't work and one works. And to your point, we don't have a good answer yet. And so oftentimes it's a discussion with the patient. Now, if I have a patient that's TKA coming and they have hemarthrosis, then I'm really obviously focusing on GAE. I tell them look, we'll do the GAE. It should help you if the swelling, everything goes down. However, you're still having pain, we can always talk about the nerves down the road. But a native knee osteoarthritic patient coming in with a Kellgren-Lawrence 2-3, which is the most common that we see. We see 4s as well, but 2-3, I don't have the data to say we should absolutely do one over the other. And that's what I tell them. And we have just a discussion. I said, listen, we can approach the nerves. We can do the test or prognostic block. And if that works for you, great, then we'll do the ablation. Or we can do a single procedure for you with one needle that goes in. And we can address the arteries, which would ideally help reduce some of the inflammatory components of the synovium that are likely contributing. And so I honestly just kind of leave it up to the patient to really make that decision. I tell them one does not obviate the other. So let's say we do a GAE and you still have pain, we can always approach the nerves or vice versa. So that's the KL2, and 3. The KL4, they're usually heading towards a knee replacement unless there is other comorbidities that can help them. Some of our orthopedic surgeons kind of give a green light when they refer this and say, do whatever you want. Some of them are a little bit hesitant about us removing an arterial supply to a joint when they know they may enter the joint in 12-month period. Even though there's no real data to say there's adverse outcomes, it's just something to be mindful of. In our data, Kellgren-Lawrence scale had no effect on outcomes from GNA. So I talk to the patients about both. I tend to lean a little bit more toward the side of the nerve when it's that severe. But I still tell them that we have the GAE available as an option should the nerves not work. And it's really, it becomes a discussion. And now I've had patients, though, that they're referred to me for nerve ablation, right? And then you see them in clinic, and yeah, sure, they have pain. Maybe they have like a KL3, but they're having these just recurrent effusions in their knee. And I know that I can ablate the nerve all I want. It's not going to take care of that, right? And so in those unique circumstances, when there's osteoarthritis, there's effusion, you can start really talking about both, and maybe starting with the GAE to see if, okay, we're going to reduce synovial inflammation, hopefully reduce the effusion. And if that takes care of the swelling, but their pain's still there, then of course we'll do the GNA. Or you can potentially talk about doing both at the same time. You know, do a tap for them, get the fluid off, then do the nerve block. And if they do well, maybe combining both procedures in one setting. Done that a few times on a very handful of very select patients. Oftentimes those patients were very nervous to get any procedure done because they're just scared, and you want to have the sedation and everything, and in some cases even anesthesia if they're that nervous about the procedure. But it's not unreasonable to think about these things. But to your point, I don't think we have a clear-cut answer, of what we should be doing for those native knee osteoarthritic patients, Kellgren-Lawrence 2 and 3. And I think, it's going to take some time to find out.
You're right. I mean, it's an algorithm that is constantly evolving and changing as we get new data, and the space is still relatively new, right? And I think to your point about, preoperative knees that are getting GAE, the UCLA group, as has some data out there that really showed no adverse effects, as you said, right? So there is data that supports that. Obviously, we're not in the OR with our colleagues in surgery, so if they're concerned, then obviously we're concerned about it as well from a healing aspect. So I think that's also helped kind of push the needle towards resorbable embolics in the GAE space. For my practice and in my partners, Teresa Caridi is one of my partners, we tend to pre-screen with an MR and look for synovitis and effusion and then decide between GAE, GNA. I think one place I struggle, I totally agree with you, between KL2 through 4. One place where I struggle, and I also find it very interesting, a lot of the European studies tend to include KL1. A lot of the US studies tend to not include KL1. And as you know, X-ray is not always accurate in terms of diagnosing KL1 through 4, right? There are complexities to actually just taking the X-ray that alter the interpretation. So how do you deal with the KL1 patients?
So we see the KL1 patients also.
Yeah.
And totally agree with you. If they're coming in with an X-ray, honestly, most of them are non-weight-bearing X-rays. And then if you're a lot of the eye of the beholder at that point as well, and the KL1 is a KL1, it looks like a total normal joint, we'll have a very similar discussion, but I'll err on the side of, look, I can do a nerve block for you. I need you to go back to PT, though. Because whatever I do is going to be temporary. And this is probably something that we can maybe reduce some pain. Ideally, strengthen the muscles around your knee so we reduce the progression of the osteoarthritis. And anything we're doing, right, we're not reversing time here. We're not inserting cartilage here. My goal is to reduce pain, get them functional, get them into a weight loss program if the goal is to have a knee replacement and they're not quite there yet because of a BMI issue. We see a lot of that in our practice. Or get them to PT so they can strengthen their muscles around their knee. And that's what I talk to the KL1 patients about. It's that we can do the nerve block. And if it works for you, we'll do the ablation, but I'm sending you back to PT. Often when I hear, right, when I see these patients in consults, I tried PT, it didn't do anything for me, or I tried PT and it made it worse. And I say that's reasonable, that's fine. I hear that a lot, but I want you to go back after we're done because I want that progression to kind of stop at the KL1. In our data, we've analyzed everything. The KL1s do well after the genicular nerve ablation as well. So we don't see discrepancy between any of the KL scores, and we did a multivariate analysis looking at that. But it's a little bit nuanced conversation with them.
Yeah, no, it's a great point. And I mean, I assume you prescribe PT for your GAE patients as well. I think these post-op regimens is really, really important. As we as interventional radiologists historically have just not really worried about that, right? We've just sent them back to the referring physician. But kudos to you and your team for really developing a post-op algorithm. It's something for all of us to really follow. So we talked about WOMAC, KOOS, and VAS. What about more objective functional testing, chair stand tests, stair climb tests, things like that? I think one of my challenges with WOMAC and KOOS is the subjectivity of it on the patient side. What are your thoughts there?
Yeah, I mean, to be honest with you, we're pretty reliant on that. However, the stair climb is interesting, right? Because I would say half our patients, that's the triggering symptom is climbing stairs, and they'll just tell you outright, like walking up and down stairs hurts like heck. And so if we can get the patient, if they're physically there for the consultation, a lot of them are virtual, that would be, that, in my opinion, that would be the right test to do. But you have to also ask what the triggering symptoms are for those patients. And it may not be stairs. It may be something else. So while we try to replicate those, if they come into the office, a lot of times they don't. And so we unfortunately don't do that. But that's just the nature of our practice where these patients are coming from.
Well, and it's one of the challenges in the literature, right? Just because the WOMAC is not significantly improved, but if the patient is happier and more active and more functional, and we're not accounting for that, then, the studies may not show a benefit, but there is actually a benefit, right? So,
right. And you have to think about this too. Like, there's other procedures that we do for pain. Like we do quite a bit of basivertebral nerve ablation as an example for axial back pain. And in some patients, you'll see that their VAS score decreased, but maybe it's not a dramatic drop, but their ODIs, their functional scores really, really improve. And so, I mean, you're right. I think, we probably could be doing a better job evaluating the objective functional capacities of the patients from a research standpoint, and looking at this and how it works. And I think it's something to keep in mind as we think of future studies.
Yeah, absolutely. And everybody talks about MCID and minimally clinically important difference, right? And how in our targets in the literature, do you worry about that? Or do you just, you mentioned 50% pain reduction earlier. Is that your just general target?
Yeah, so that's our general target. Again, that's how we started the practice. And that's based off some of the original literature, looking for that threshold for the block, then to proceed with an ablation. That's kind of what we describe. The MCID is, I think, gaining more importance as we are doing these studies and we're looking into the patients. And I think it's going to actually be incredibly important to report and discuss as we go forward. But from a pure discussion with the patient consultation, we're focusing more so on that 50% at this point.
Well, it's MCID itself is a little bit of a moving target, right? So it's a little bit of a challenge.
It is. Yeah. I mean, it's been brought up. We looked at it in a submission to SIR last year for our GNA population as well. So it's definitely a moving target, but it's something that, is absolutely worth further analyzing and thinking about when we start looking at these larger studies for both procedures, GAE and GNA.
Great point. Is there a role for MRI? In the GNA population specifically, sorry.
Yeah. So it's a very good point. I would say 25% of patients come with an MRI.
Okay.
Most of them are coming in with plain films. So usually it's without contrast, although I'm seeing some that are being imaged with contrast and you're looking for synovitis at that point. And so I had a referral on Thursday when I was in clinic for GNA, but again, I have my spiel. And they happen to have a contrast-enhanced MRI of the knee that was done in an outside facility, and there actually is some synovitis on there, and that changes a little bit of my discussion with them, right? If they have KL2, native knee, but they have a little bit of reactive synovitis, I am going to maybe start to talk a little bit more heavily towards GAE because, in my opinion, I want to reduce that swelling. I want to reduce that inflammation, and I personally feel that may be the better way to go. That being said, in terms of the logistics of getting these patients in, right? So majority of ours are referred by our orthopedic surgeons, or in case, one of the reasons to do physical therapy referrals is you'll get relationships with physical therapists that may send patients into you as well. However, most are sent by orthopedic surgeons. That means that they've been dealing with this pain for some time. They may have tried corticosteroids or hyaluronic acid or PRP or something else. And they may be getting to you after going through a lot of other, steps. And so MRI would be great, I think, if we had it, but I don't think it's necessary to proceed with the procedure. I wouldn't withhold, doing the block and ablation if someone does not have the MRI. But in my mind, I'm like, okay, maybe we do need an MRI if something doesn't work for them to further evaluate this.
Yeah, it's a great point. And, we talked about it a little bit earlier. I know I'm kind of using it to pick which pathway I want to go down when I'm able to get it. But there is, there's a time component. MR scanners are busy in academic centers and, all over the country, and insurance doesn't always actually cover it. And that's been one of our problems as well. So it is an area of evolution, right?
Yeah, completely agree.
What about the data? What about GNA versus other therapies? Is there any GNA versus GAE data, or just strictly, corticosteroid, hyaluronic acid injection?
Yeah. So in terms of GNA, there's a couple of studies comparing corticosteroid injection and GNA. These are cooled. They carried it out to 6 months, 12 months, then 24 months, and 3 subsequent evaluations of the patient, all of them showing a significant reduction of pain and functional score. They did the same thing with hyaluronic acid, so single injection hyaluronic acid, comparing it over those time points. So 2 different randomized control trials carried over 6 months, 12 months, and 24 months, showing a significant reduction of pain and functional improvement with those patients over that time period. So that's cooled RF specifically. So that's some of the data that is actually already out there for the GNA patient population, which, is I think helpful in terms of discussing what is available for patients. Like if a patient just comes and sees you and they're not really sure what to get, it's very reasonable to say, okay, you can always start with a steroid injection. You can start with the hyaluronic acid if you want to do a little supplementation there. However, this is what the data is showing. And again, these are RCTs, so they're, it's the data is good. There's also, again, that first study in 2011, which is really effectively a sham trial that showed superiority. And now that was not with cooled, that was traditional. And then you have these meta-analyses as well that have looked at the different modalities of RF at this point. So I think the data for GNA compared to some of the other, I like to call them needle procedures, minimally invasive procedures of the knee, that exists. You may not be seeing the patients prior to them having had something else, but that's fine. And that's how we started, our program. We started seeing them after they had steroid injections, and maybe the steroid injection worked once and then it didn't work again. Hyaluronic acid didn't work, something of that nature. PRP is a little hit or miss, because sometimes PRP works very well for these patients, sometimes it doesn't. The European literature for PRP in the knee is actually very robust. No, GAE versus GNA, I think that's going to be right. The once we have more data on GAE and types of embolics to use and things of that nature, a GNA versus GAE trial for native knee OA, Kellgren Lawrence, 2 and 3, if we make it a very nice tight protocol, that might be an interesting study to look at. Because right now, I feel that a lot of the data is not real data yet. It's a lot of anecdotal experiences. You can do propensity score match, right, for these patients. But, in terms of an RCT that's out there and published, I think we're still waiting on some of that data, which is, again, it may speak to being able to offer both, right, in your practice, is being able to do both. And I think that's what sets us apart from, we have wonderful pain physicians, wonderful PM&R, but they don't dabble with the arteries like we do. We don't really dabble. We pride ourselves on being endovascular specialists, right? And we have that ability to really offer something additional to the, image-guided needle and pain procedures.
Yeah. And all great points. And, I think one of the things, and we offer both at UAB, you offer both at Georgetown Hospital Center, right? So, but, the interesting part to me is the durability of therapy for GNA, right? Up to 24 months, which we're really just now starting to get on the GAE side. So that's really nice to see on the GNA side. I guess the other corollary to this, you mentioned a sham study. Is there a need for more sham studies, or is it better to just, and this is also controversial, but should we just be comparing to best alternative care at this point?
If you look at the sham trial for GNA, right, it was done over 10 years ago, as you mentioned, 3 nerves, traditional, conventional, RF, maybe not technology everyone's using, maybe not all the nerves everyone's using. That being said, it's out there, right? That data's out there and it's good data. It's a randomized control trial, so it's good data. If you were to do another sham trial, I don't really know if it would add much to it as opposed to something that's established versus something that's new. There's probably not a harm in doing it, right? The question would be, okay, let's say cooled gained a lot of popularity in the past 13, 14 years. Would that be the trial to do for a sham trial, just a cooled technology? But, comparing a new technology versus existing proven technology, I think is very reasonable. I don't know if we necessarily need another sham trial for that. And we have the sham data for GAE as well at this point as well. So, doing another, I think doing established minimally invasive procedure compared to the new procedure may be more valuable. So again, hyaluronic acid or corticosteroid injection versus artery embolization, or GNA versus the artery embolization.
Yeah, great point. I think, if cryo were to gain more popularity on the GNA side, would that question be asked? There's a recently approved NIH study for GAE versus sham as well. So we're going to get more data on the GAE side. I know we have some. So it is, we're quickly adding more literature, which is fantastic. So yeah, great points.
And I don't want to, I don't want to discount the cryo part because I think that's going to be very interesting, right? Again, you don't have the thermal damage. We love cryo for a lot of other nerves that we treat throughout the body, right? It really does work so well. And have to really thank Dave Prologo for getting that out of the literature and being such a proponent of it, for other parts of the body as well, as he does a lot of stuff in the joint space. But I think cryo may have a nice role to play here as well, just based on the nature of how it works. And you and I have talked about this before about we see the benefits of cryo to be. So I'm excited to see where cryo takes a role with this.
Yeah, absolutely. Myself as well, and it'll be interesting, 2 to 3 to 4 years, right, as the therapies continue to evolve. So I want to switch gears a little bit. Talk to me about post-procedurally. What are you counseling the patients on? What are you looking for in terms of pain recurrence and potential for retreatment? What do you consider a failure?
Yeah. So first things first, I tell the patients.
Notice I whispered failure because that never happens to you. So yeah.
No, we listen. We have patients that don't get the treatment that they wanted, but that's why we have other stuff that we can do. So after the procedure, I tell them they're going to be sore in their knees. Right. It's not going to be like the day-to-day soreness. It's going to be more like they got a flu shot, and that's because you are going, deep to the muscle onto the cortex, or right adjacent to it at least, to get to the bone. That soreness goes away usually 24 to 48 hours. I tell them just to take over-the-counter Advil Tylenol. I don't send my GNA patients home with a Medrol dose pack, script NSAIDs or oxycodone. The GAE patients, I do send them actually with a Medrol dose pack. I send them home with some NSAIDs because I believe, the GAE, you have this immediate inflammatory response and then that calms down. The GNA, I don't. And then I send both patient populations to physical therapy. Ideally, I'd have them start the following week. I don't want them to be on a couch. I want them getting some mobility to their knees. Now, that being said, I think physical therapists are inundated with patients, and so getting in the next week is sometimes difficult. In terms of pain reduction, we discussed, 6 weeks or so until we see the maximum effect. When the pain recurs, right, because these nerves, they're myelinated. They're going to grow back over time. And I tell them based on the data, right, it can be anywhere 6 months to a couple years. On average, we're seeing about 18 months for our personal patients or so. If they've had a successful ablation, which again is that subjective 50% reduction of their pain, and they want to have a repeat, then we do not need to have them do a block again. We can just go ahead, write a quick note, and then we'll schedule the repeat ablation. Let's say, though, when we talked about it before, that the ablation block-worked ablation didn't work, or ablation lasted for a very, very short period of time, meaning less than 6 months. And usually if it lasts less than 6 months, it's pain recurrence within like 1 to 2 months. It's pretty quick. Then we talk about ethanol, but I also, have already once talked to them about GAE, and so we bring it up again, saying, okay, listen, the block worked, this didn't work. We can try the GAE for you to see if that will help you. And making sure that we have that other modality that's there for them. And again, vice versa with the GAE. I think I saw the first patient I treated she wants to have it retreated, her GAE. We did it a few years ago. Pain has started to recur. She is someone that has native knee with a fusion that she was getting tapped 70 cc's every 4 weeks by her orthopedic surgeon. It went down to 70 cc's every 8 months or so. And now that part didn't really bother her, but the pain has started to come back. And so I think, we don't know when the GAE pain will come back, but the GNA pain is pretty predictable. And I just tell them it's going to come back. That's what they need to know. It's going to come back, but we can treat it again.
But this is a bridging therapy, right? And we know that we're not modifying the joint, we're just bridging, and then hopefully adding some structural support with PT, like you said. So, is interesting. I was at SIO a couple weeks ago, and I forget who, but somebody gave a talk on cryomyositis after cryoablation of skeletal tumors. And something that I just saw anecdotally as a junior faculty several years ago. And the first time I saw it, I freaked out. I was like, what did I do to this patient? They're howling in pain. Do you think with RF ablation or pulsed or cooled RF ablation, or maybe not pulsed, but cooled RF ablation around the knee, there is a little bit of myositis that is causing this pain as well? That's in that first 24 to 48 hours.
Yeah, I would imagine so. I mean, you're causing definitely, it's limited, but it's still a thermal destruction. The nerve, but you're hitting the adjacent muscle as well. The same argument is why you might see a little bit of osteonecrosis, right? Especially if you get your needle too close or even into the periosteum, you're going to see that. Now, ideally, if you're getting in the bone part, you're going to see your impedance shoot through the roof, and the machine, you should kind of be aware of that. But certainly, I think you could definitely get some muscle injury, and that may contribute to some of the pain.
Okay, but hopefully short-lived, as you said. So.
Yes, exactly,
Okay,
exactly. Yeah.
Now, like if we look at the surgical literature, there are defined subcategories of patients that just tend to have poor outcomes, right? Psychiatric disorders, fibromyalgia, things like that. Do you think there's a role for kind of separating out those patient populations for GNA specifically, and GAE, quite honestly, and outcomes there?
So yeah, that's a very good point, because you do enough of this, you're going to see that patient population come to you. And when we started doing this, I would, in my mind, think it's probably not going to do well for them, especially fibromyalgia. These are the patients that, you're prepping the knee and they're in pain, just from a chloro prep, or the metal that you're touching over the knee under fluoro to mark your entry point. The shocking thing is that they actually did well. So I think for a study purpose, right, I would probably exclude that. I would have that as an exclusion criteria, because it's going to be overlapping. Likely they've been on and off some type of pain regimen, or, maybe even a neuromodulator regimen. But from a clinical practice standpoint, we thought that would have a negative effect. And when we sub-analyzed or did our multivariate analysis, it had no impact on the outcome.
Okay. Wow. That's fantastic. And so maybe an option for those patients that maybe, are going to have poor outcomes post-surgical, maybe you can kind of add this in and optimize their, post-operative experience.
Yeah. And if they're really having that bad of an outcome after surgery and your surgeon is a good referrer to you, they're probably going to wind up at your door anyways.
That's valid. That's a great point.
But it does not stop me from doing the procedure. I have a very careful discussion with them about expectations. I think underselling a lot of the pain procedures is, in my opinion, not a bad strategy, just to really temper expectations. The problem is that we have so many patients that come to us for different pain procedures that we do. And while we're obviously trying to improve pain, it's not like, okay, this is this new procedure with one thing we're going to do and all your pain will be gone. And I try to get that point across, is my goal is reduction of pain, not elimination. And if I tell them that's going to be eliminated, then the problem is that I think that word gets ingrained and they hold on to it. And when it maybe is reduced, but not completely gone, that's where the quote unquote poor outcomes may come from. So something to keep in mind as you're talking to patients.
That's a very good point. I mean, that goes to setting expectations and then also just communicating with the referring physician, whether it's a rheumatology, orthopedic surgeon, primary care, whoever it is. We have great relationships with our orthopedic team and they're wonderful, and whatever we can do to kind of help them. They have the ultimate therapy for this patient population, right? We're trying to bridge them to that therapy. So you talked a little bit about TKA. Any differences in technique for the TKA patient population?
No, it's the same technique, but just know that you might find some scar tissue there. You might be going through some fibrotic tissue as well. And you're going to have to probably push a little bit with the needles. It's more of a tactile component you have to be comfortable with. Warn the patient too, let them know that they're going to feel a lot of pressure with this, depending on where, your needle is entering. And it's just that expectation. You'll also, if you're doing RF for that, you'll see your impedance probably fluctuate quite a bit in that area. It's not so much because of the metal, it's more so because of the tissue that you're fighting that conduction against. But that being said, I treat them in terms of the anatomic locations of the nerves, same technique that I do for all my native knee patients. And again, I think it's a good option for the TKA population for pain control.
For sure, and I think we're seeing more data come out of that population as well, and we will continue to as well. But it is usually a midline incision, so your suprapatellar access in particular, do you move that at all in the patients?
So I like coming from actually a lateral to medial approach from that. And you can come in essentially the transverse plane to get to the suprapatellar notch there. And, you're going to be fighting through scar tissue, through tendon. Everything's going to be a little bit stiffer than a native knee if you're going to come straight down the barrel. It's a longer path, obviously, if you're coming from a lateral to medial approach, but it will be under the tendon, right? And then you're not going to be fighting the scar tissue.
That's a great point. And you alluded to it earlier. I actually do the same for inframedial patients and very thin patients where I don't feel like I have a lot of tissue. I come from a little bit of a lateral to medial approach and longer throw that way as well.
Exactly. And at that point, you just have to kind of know if for some reason the length of your needle, maybe a little bit longer from that one location, you may want to open up a longer needle kit. It's just something to think about so you're not opening up multiple kits for a procedure.
Good point. What about the future GNA? What's missing in the data pool?
I honestly think that the liquids and then the cryo needs to be evaluated a little bit further. I think RF has been proven. It's, worldwide are very common technology, but I think we have other tools here that may have better or superior outcomes compared to what's already there. So I think it needs to continuously be studied. What I would also like to see is more data on adherence to physical therapy after the ablation, just to see that the functional component from the physical therapy is improved. I tell patients, we're going to reduce your pain, but the PT is probably what's going to get you to where you need to go in terms of pain and mobility. I get so many patients, and I'm sure you've seen them too, that they're saying, okay, yeah, I have pain and my joint's really stiff. Well, I could probably help with the pain. The stiffness, though, this is not going to probably help that. And you need to really move things around. And so I want to see, some of that data sussed out there to essentially really strengthen my argument for at least our regimen of getting everyone to PT after the procedure.
That's great. I mean, I think very, very good advice, especially for, people that are building practices out there, right? Kind of a comprehensive approach to how you approach GNA. So I really appreciate it, John. Anything else you want to bring up or talk about?
I think we are at an exciting point in IR with this. We're having multiple modalities to help our knee osteoarthritic patients and post-TKA patients. And for those out there who are looking to build a practice with this, don't forget that the orthopedic surgeons are seeing, 60 patients a day in clinic. And if they can operate, they need somewhere for these patients to go. And it may be easier than you think to build a practice like this. So much so that once you open the floodgates, you need to be prepared to take on the patients, both from the clinic side as well as the procedure side. But the demand is absolutely there. Again, I think it's an exciting part of our specialty, and we're looking forward to all the research that hopefully is going to come from both GAE and GNA, and trying to understand what to do where, and maybe offering both for certain patients.
Yeah, absolutely. Great points and great advice, John. With that, thank you so much for being on today. It was wonderful to kind of pick your brain a little bit on GNA. I definitely learned things today. So John Smirniotopoulos, thank you for being here, and we'll catch up soon.
All right. Thanks for having me.
Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable MSK on Instagram, X, or LinkedIn. BackTable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.